Okay, I think we probably should make a start. Kartik, are you okay to start the recording?
Yep, sure. So it's recording now.
Thank you. Lovely. Right, okay, so we'll make a start. I'm hoping that more people may well join. If not, obviously we can use the recording and people can look at it after. So welcome to the second AHP day. So this is our second day of LLR AHP week. For those of you that don't know me, I'm Debbie Blaze. So I'm a clinical service lead for Neuro and Stroke Services. I'm an AHP, I'm an occupational therapist. So thank you for those of you that have attended. We've got some really great sessions and obviously an opportunity for you to ask some questions as well after each of the sessions. Please feel free to put anything into the chat that you want to do, and also raise your hand. What we'll try and do is try and coordinate the questions at the end of each session, but please pop things in the chat as we go along so that we can monitor that. So we are recording. I hope that's okay. If anybody's got any concerns, just let me know. We will record. We'll pop it on YouTube, and we'll also be popping it onto the Our Futures page as well afterwards, so for other people to see around the country. We will put the Our Futures link into the chat. I think Lucy will pop that into the chat. Lucy's going to be my support today in terms of the IT. We really pleased to welcome is Rob Goddard. Rob is the AHP Productivity Advisor for NHS E&I, and he's going to give us a fab presentation. It's been really great to have him with us in LLR this week. So I'll let him introduce himself because I'm absolutely certain he can do that, and then I'll pass over to Rob. So if Lucy, if you want to start sharing the presentation, that'd be great. Have we got any questions before we start from anybody? No. Okay. Over to you then, Rob. Thank you.
Yeah, thank you very much, Debbie, and thanks a lot for inviting me. I dare say you're getting a bit greedy having AHP's day all week. You know, you starting early, but that's great to see, so we can take the opportunity to celebrate the work. So as Debbie said, my name's Rob Goddard. I'm currently working on a secondment as the AHP Productivity Advisor with the Clinical Workforce Productivity Team at NHS-IE. My substantive role is that I'm a Chief AHP in South Tees Trust, which is Middlesbrough, North Yorkshire area, and I'm a physio by background, so I am an AHP rather than just somebody who might have some ideas about productivity, hopefully a little bit of both. So if you don't mind moving the slides on, Lucy, that'd be brilliant. That's great. I was hoping for no IT failure sakes. I've had 3 significant failures this morning already with a child's dental appointment, a dog being sick, and the school ringing me about my son as well. So I'm doing well today. So hopefully we'll get better. So first of all, thinking about productivity. If you look at a definition for productivity, it all gets very industrial, and you get the ratio between output volume and the inputs. So you know what you put in and what you get out and all that sort of thing. Now, I think when you involve people rather than a production, your good selves as healthcare colleagues will probably say, well, yeah, that's fine, but did it work well? Was the service effective? What were the outcomes for the patients? How did my staff feel about delivering that care? So I think there's probably a bit more to the dictionary definition of productivity when we're thinking about in the context of the NHS. Moving on, please, Lucy. So just looking up some definitions around the NHS, and I'm not sure about the words that are there precisely fit, but to me there's 3 significant elements to thinking about productivity in our work. There's the resources, and the main one of those is our staff and the human resource that's available to deliver care, because clearly that's the absolutely key component in delivering care. There's something about the demands in the bottom right-hand corner as you look at the screen, so it's labelled operation, but the demands and what we're actually delivering, so the clinical pathways we're delivering. And there's clearly a significant element around the clinical outcomes and quality of the care we're delivering as well. Just move on again, Lucy, that would be great. And thinking about the other factors that might involve in productivity, and this is lifted from what was termed the AHP Balanced Scorecard, and thinking about workforce productivity and what that means, and bringing lots of other indicators as well. So there's 4 sections there, and the aim is to try and get your Venn diagram sweet spot and get a mixture of them all, as is the case with everything, isn't it? There's never one answer. It's always trying to balance lots of different things. So we've got the AHP service indicators, the quality as a key element at the top there, and moving clockwise round. Thinking about developing workforce safeguards. So to me, There's a document produced, I think it was 2018, around safeguards for workforce. It's about establishment setting. And the absolute aim for that would be to have some randomised control trial, well-researched, evidence-based establishment setting that's there to say you need 10 physios, 10 OTs, 5 dietitians, 25 speech and language therapists, and that in a little recipe will deliver you wonderful care across whichever pathway you're talking about. Now, we haven't got to that point yet. So a lot of the work we're doing now is modelling across pathways to say what establishment would fit, what might work well, and then can we evidence that with the outcomes and the quality that we're delivering. So we're trying to work through that, and I think a lot of what I'll mention today ties into the factors we need to think about when doing that. Going around to 6 o'clock, there's the metrics there we might use. The clinical hours to contact might be a metric you've heard of. So it's looking at the clinical hours available, how many contacts you've got, and does that feel right that there's approximate need of 40 clinical hours to every contact you have with a patient? Is there an opportunity that other staff might be able to support you? Is there an opportunity for our non-registered workforce to be able to deliver some of the care when there's pressures on, well, not just when there's pressures on, just to deliver good quality. But obviously we know that we can't just produce an extra 5,000 radiographers. They're not sat there doing nothing. So we might have to think about innovative ways of using the workforce and maintaining the quality. And also, obviously, the main thing in all of this and the main thing in everyone's working lives is supporting each other, supporting our staff, retaining our staff, obviously not denying the opportunities to move on, not locking them in a room to retain them, but hopefully you'll provide opportunity in your organisation where staff can progress and feel happy because they're well led and they're comfortable in the role. So just a few more factors there. But I think the key things I'll try and talk through are the 3 main domains of looking at your capacity, looking at your clinical demands, and also looking at your outcomes. So I'll focus on those 3 things as I move through. So next slide, please, Lucy. So clinical capacity. Hopefully I'm not teaching anyone to suck eggs, but we need to consider lots of elements when we think about what capacity is actually available to us. So to fully detail your capacity, we need to be aware of a number of factors. Someone's contracted hours, I think that's fairly self-apparent. When they're not at work, so annual leave, bank holidays, but also when are they not patient-facing. So yes, you'll have clinical care percentages. So you'll have a rough idea of how many hours you want somebody in front of a patient. But also that person will need time to develop. They'll need time to work with their team. They might need time to supervise others. All sorts of different factors that might count as supporting professional activities when you're considering the job plan. So how many hours are actually patient-facing? Also, you might have vacant hours in your team, so your capacity might be limited for some reason. And we will, I know everyone wants to be at work all of the time, but there will unfortunately be an element of sickness absence to capture in as well. So there's a tool called the Productive Hours Calculator, and I'll assume these slides will be circulated around. So there's a link there you can click on, which takes you to a document which would incorporate those factors within your clinical capacity and give you clinical hours that your team can provide. Move on, please, Lucy. So I've sort of mentioned job planning there, and we've been working with teams to look at their capacity, and it's really key that people begin to consider job planning. The long-term plan asked for e-job planning to be in place this calendar year. That was prior to the minor hiccup we've had of a pandemic, which has obviously delayed things a little bit. But also there's something else that wasn't available there, is the funding to fund the e-job plan licenses. So people haven't got that e-job planning there, and I think there's a very small number of trusts reporting that they do have that across a wide number of staff. However, the principles behind job planning will be absolutely essential to modelling your capacity. And we've worked with a number of organisations around how they're proportioning the clinical care available for the bands of staff. Now, some teams have taken a uni-professional approach and then quickly come together with their partners in another profession, another AHP profession, and realised it's been the same for each profession. There's been no justification or reason that an occupational therapist needs more clinical hours than a physiotherapist or any other profession. And the sort of generic area where they've come to is detailed in that slide, that your band 2 to 4 staff are around about 90% patient facing, and then you've got the percentages there for the other bands. When you get to band 7 and above, it's really tricky because people have lots of different elements to the role, so it's hard to give a generic point. And just my caveat with sharing those figures is they're born from organisations who have had a rollout of job planning, some professional judgment with a chief AHP group that was in the London region, we discussed it. And also some national benchmarking. The acute therapies did a national benchmarking exercise, and we asked teams where they sort of sat on their clinical hours for staff. Now, those all figures come within around about 5% of those numbers. So as a generic starting point, I think that's a pretty good place to start. But clearly, you discuss it with your teams and individuals to look at variance from there. You may have staff who have more responsibilities for whatever it may be. Health and safety reps. You might have someone who plans your student placements need more time for that. So the things will vary, but that's sort of a reasonable starting point for discussion. So when you apply that individually agreed direct clinical care hours and the leave entitlements, it will give you an accurate detail of your team's, your actual available hours for your team. And also consistently categorising things in your job plan. If you went to our futures page, which I think will get shared, there's a document on categorisation of job plans. So what sits with direct clinical care, what sits with supporting professional activity, and what sits in other areas. So you'll be able to hopefully consistently apply those. And that category document was from a focus group. It's not been nationally published as this is the be all and end all, but that focus group, which encompassed, I think it's about 50 people from non-medical professions, so nursing, pharmacy colleagues were involved. That's where they agreed that was reasonable. So I'm not saying it's a national decree, but I'm saying again it's probably a reasonable place to have a look at, so you consistently categorise stuff. Just move on again, please, Lucy. So that's just an example of a spreadsheet, a template of your contracted hours, your leave, and how that works through. And if you've got some skills in Excel, you'll be able to just get to a point where you type in your weekly hours and have the calculations to work that through, and then apply your percentage DCC. And it's really small, but I put 2 band 7s in there, put one at 50 and one at 70%, just to show the variance in the actual clinical hours that will be available in a year. So you can see that the category that is an important factor in the capacity modelling. And you'll note that those percentages I put in aren't the same as those that I just said, because we know there will be variance. So in this team, the discussion might have led to that variance. It's clearly a fictitious example, but it's just to make the point. Okay, just move on again. Thanks, Lucy. I mentioned our futures page, and there's some job planning resources available there. So if you use that link, there's a simple sign-up process, and there's some generic templates there. There's a categorisation document, and we leave it on that page as opposed to me circulating documents now, because they might be amended as things do. We review things and they might get amended. So I think we uploaded those. June we've got there. So it's only a few months old, so still probably quite up to date. The other point in the capacity that I didn't note that I meant to was just around the proportion of your registered and unregistered staff. So I think when we think about demands, that's a key thing you can match. You say, right, in my team, I've got 40% of my staff are non-registrants and 60 are registrants. Then when we look at the demand modelling, we can look at the work required and the clinical interventions, and hopefully look to if we can match those. So you've got a rough proportion that's in agreement with the demands that you're looking at. There's some resources there to look at anyway. I've talked a little bit around job plans, so hopefully you've got a reasonable position to look at job plan if you're not already doing so. Just move on again, please, Lucy. So I'm thinking about demands. So really with this, we're trying to say your teams will cover a variety of different demands across a pathway. It's not going to be in one ward setting, it can be across a number of settings. And if we understand the time required to deliver each step, we can hopefully model the demands you need to match with your capacity. So we've done lots of work at regions identified discharge to assess as a priority area. So we're working through that with some regional groups. And what they're saying is, right, for my pathway 0 patient in an acute setting, this is what I need to do. We need to identify the patient. We need to make sure they've got some basic equipment for discharge, and then they can be discharged. How much time does each of that take? Was it a registrant? Was it a non-registrant? Okay, great. We've got a total time there. Pathway 1, the same thing. And then into the community setting, what interventions, what assessment, what follow-up are required. They give us a time requirement per patient along that pathway. We then might link that to existing activity data to say I have this many pathway 0, this many pathway 1 patients. That'll allow us to give a total amount of time that you need to cover from your team. And obviously we can review that against the capacity. So it's quite a detailed piece of work to get to that point. But if we were to take that time to go through each pathway, hopefully you'll be able to look at the capacity in your team and does that match. But the key thing to consider there is, let's think about pathways that will give effective care, not necessarily just what you're doing now. If you model what you're doing now, if you put in what you've always done, you get out what you've always got, I think is a reasonable saying. So if we say this is what we need to be effective, then we might model and see some opportunity. There might be some variation we can look at and say, is that warranted or unwarranted? Can we take opportunity there to improve somewhere? So think about your modelling, think about what would be effective. Not in an absolute blue sky world, because we know that people, there isn't an infinite resource, but in a, just being able to deliver effective, reasonable care for patients. I mentioned discharge to assess. Other areas we're looking at, there's some teams looking at T&O pathways, and I'll come on to that a little more detail about another tool that's being looked at in it shortly. And also we've got some teams looking at critical care as well. The idea from my perspective is getting an effective methodology we can apply to lots of settings. And if we achieve that, of course, we'll share that, and you can steal it, pinch with pride and use it in your settings. That'd be a great position to be in. So just next slide, please, Lucy. So I mentioned at the start that we would aspire to get towards an establishment setting tool for AHPs, and previously there was work that looked at doing this along a staffing per bed or per establishment area, but because we work across pathways as AHPs in the majority of circumstances, that modelling just didn't really fit the way AHPs work. There might be a minority of staff groups who it would fit. You might think stroke and a stroke rehab ward. Well, my staff generally stay just on that ward. So I could probably use that sort of methodology for that team. But the problem might only fit your OTs and physios, because your speech and language patient might get pulled to cover other clinics somewhere else, and not solely in that ward area. Probably depends on the size of your stroke unit. Critical care and physio, you might be able to work that through for that, but there's really a minority of areas where that staffing per ward or establishment really fits. So the focus has been looking at pathways of care and delivering effective pathways from AHP teams. Trying to work through a metric of clinical hours to contact, not necessarily to compare between organisations, because everyone's different, but to allow leads to say, does that feel, that clinical hours to contact, does that feel to be right for that speciality? Is it right that per contact that takes a clinician 27 minutes, roughly? Does that feel right? In a community setting, it might be 2 hours, because you've got to travel there, and you've got to get, you've got to get there, you've got to get equipment there. It might be, so there's going to be lots of variance depending on the setting, and you might deliver a similar sort of care in a different setting, so therefore there might be quite a bit of variance between organisations. You may find an organisation very similar and can compare reasonably, absolutely fine. But I suppose we want to avoid just people saying, well, this is this for me, it should be that for you, when we know there will be a lot of variance in how people are set up. But hopefully a good judgment point for leads to think, is that reasonable? There's another tool called the Mental Health Optimal Staffing Tool, which includes nursing, physio, OT, dietetic and SALT requirements to give interventions on specific ward settings. An implementation in some trusts is occurring, and there's been mixed feedback around it, and I'm trying to work through with an organisation in Essex about how their interventions and mapping is going to feed that back a little bit further. But what that gives you is a total whole time establishment that's required, not broken down by profession. So the professional judgment in your team would say how many of those should be nursing, dietitians, physios, speech or OTs or support staff. And also the Chief Allied Health Professionals Office team commissioned some proof of concept work with Kendall Bluck. And this tool was called AHP Pro, and I'll describe it in more detail with the next slide. And that looked at matching demands and activity, and we're just collating final feedback. It's going to the People's Board on AHP's Day, actually, on Thursday, to look at the next steps for that work. Key learning point is what I've said already. It does appear valid, but it's the local capacity and demand input is key to that work, and understanding that for yourselves is absolutely key. So I think I've mentioned the other points there. Understanding your workforce capacity, identifying areas of variation if they're warranted or not, are the key points we've learned from each of those tools. Next slide again, please, Lucy. So just to talk more about AHP Pro, because it's a piece of work that's just sort of coming to a conclusion. This was a proof of concept piece of work, as opposed to this will be a finalised establishment setting tool. And a couple of trusts were involved, Eastern North Herts and Blackpool. And what they did was they modelled their clinical demands being delivered by physio and OT teams across what they thought would be an optimal pathway within T&O. So not what they were doing now, but what they thought would deliver really good care. They then took the HES data for that trust, the data saying how many units of activity they had across each of those pathways. So there's total knees, total hips in there, across, and many other things. So how many of those people were seen in the organisation? Then that led them to a total amount of time required to deliver those pathways. Then a detailed breakdown of the workforce required throughout the year, because you could look at when those patients came into the trust, and then it would deploy staff accordingly to say you need X number of staff on this day, there needs to be this many physio, this many OT, this many support. So it looked really sensible. And the outputs looked like the proof of concept was reasonable. Also, it identified an opportunity for improving length of stay if that required workforce were available. And the next steps for the organisations involved were to actually put that workforce in place to deliver the care, to then measure the outcomes and see if those improvements were attainable with those changes. So we feel there's a final report, say, going this week. It's been through a few steps already, clinical advisory group and different settings. And we feel the proof of concept was reasonable as a proof of concept, and that work should progress. Now, there's a review bid gone in to suggest we have a national programme to roll this out. But possibly the first point might be sharing the key learning points, getting the basics in place so people understand their capacity, understand the demands on the teams, and they can begin to match those together and measure outcomes. So we'll see how that lands with that group this week. I'm sure there'll be some progress. Might not necessarily be millions and millions of pounds, but I'm sure there'll be a way forward. So next slide, please, Lucy. Just to pick out another key element, and trying quite a few things together, is around how we record our staff in ESR. It's recognised that workforce data needs to be accurately collated, so we can benchmark and compare with model hospital, which is driven by the data in ESR. When that's been looked at in some regions, they've found an error rate as high as 20% when they triangulated some data. That was just based on job role titles, number of people known to be working as an AHP versus what ESR was saying. And they felt the error rate was, it's quite significant there, 1 in 5, isn't it? That was based on the task of Finnish group in the northwest of the country, and they're looking at how they can get a consistent approach to recording their staff, so we reduce the error rate. Another area that we've picked up in our team is around the area of work options. So in ESR, you code the job role, the profession, and then the area of work, which is like a clinical area. So we've looked at this with a number of organisations. We've presented a final report to a workforce group in NHSEI, and I was hoping to have final approval by now, and I should have in the next few days, but haven't quite yet, so I couldn't quite share the framework with you. But there'll be a framework to link the area of work code to the clinical area where somebody works. So you would be able to say there are X number of occupational therapists who work in a mental health setting in this region. And I can break that down further by the area of works. So hopefully it gives you a better view and a consistent view of the workforce. And I think the important point with that is we have a consistent approach. And I know a lot of you will have engaged with the Health Education England Workforce Planning Project, which has put funding in place, and hopefully we'll work this through that project to get a consistent approach to how we record our staff in ESR. Next slide, please. I think I'm coming to an end. You can interrogate me shortly. So looking at outcomes and effectiveness, I've probably said all this already, but clearly you can't leave it off. We can't just say this capacity provides this for patients. We need to know what is it delivering? Is it giving you something that's really good? So we need to think about how we measure those outcomes. Can we measure them consistently? SNAP's a good example where outcomes are consistently measured, and we can look at and benchmark against organisations that are reporting a better position, and how did they achieve that? We need to look at that, we need across the health system, because we don't just work in one area. So how do we track that in ICS systems? And then we need to hear the staff and the patient voice. How do patients feel receiving care, and how do staff feel providing care? So I think there's lots of work to do on outcomes. And again, consistency and an approach would be really good. But clearly we've got 14 different professions working across lots of different areas. So there's not going to be one outcome measure. There's going to be several that we might use. But I just wanted to make sure I didn't lose that point without offering a lot of answers at this point in time. But we need to make sure that's key and considered as well. And I think my final slide just summarises, if I've not forgotten one. So yeah, just to reinforce the 3 suggested actions that I would give you, if that's okay, would be to concentrate on those basics. So your capacity, understanding the clinical hours available, thinking about job planning, and updating ESR with your workforce data, so we've got that all consistent. Thinking about your demands and how you detail what's required for effective care, and also linking that to outcomes. And then I've left my contact details as a final slide, and you're all welcome to contact me with any queries. So that's there. Feel free to get in touch, as Debbie did, to get me here today. And if there's more to discuss, more than happy to do so. So that's the end of my slides. I just wanted to give people time for any questions or any further discussion.
Thank you, Rob. That was absolutely fantastic. Lots and lots of information there. I think it's so important that we think as AHPs about our productivity, modelling capacity. And I think what struck me as well is how we link in with other services as well, and other like system-wide systems, pathways. And I think that's what's really good. So I think if we get it right within our teams, it's a really good start. But actually, I think wider thinking as well. So that's really great. Lots of food for thought. Right, we'll open up to questions then. I think there's already one in the chat from Emma. Emma, do you want to talk through your question?
Hi, yeah, thanks for that, Debbie, and thanks for your presentation, Rob. It was really interesting. It was just a question regarding the MHOST. I work in mental health services for older people, and that tool looked really interesting to use, but it's obviously very ward-based, and my team are in the community, and I just wondered whether there was something similar that could potentially be used in the community setting.
Yeah, so there's one tool we're working on with the capacity and demand team at HSEI, and it's a caseload model is how it's been named, and there's a few. So we're sort of building that with them, and it's trying to cover a multitude of sins with it. But it originated as a community tool and originated with mental health trusts. And what that's doing is, I think, probably what I've described there, but it's a tool that allows you to input your capacity available, input your pathways, they call them your caseloads. You might have 10 different caseloads or type of patients your community team look after. So if you can categorise those patients into those caseload groups, then we could say this is how much time's needed to do that. So that's something that's in development. I think it's really interesting, and I'm just I've been kept abreast of it. I just had an updated model sent this morning that I've not had a chance to look at, but they are working with mental health providers as well to look at it. They're working with lots of different people. It's ophthalmology are really keen as well because they think they can apply it. So it might not be absolutely precise to community mental health, but I think it's really useful to look at. So hopefully in the next few months we'll be able to share something around that as well. But it's working to the same principles as I've just described. So if you were to think about what you're doing currently, I think looking at your capacity and detailing your interventions would be the place to be, and then you could potentially input that to that tool if that tool's felt to be reasonable.
I think, yeah, it would be, and I think that problem we've got is that a lot of what we do around demand and capacity is very quantitative.
Yeah.
Very much about volume, and what it doesn't pick up or isn't sensitive to is the complexity of the cases that sometimes we deal with, and that's what we've really struggled with, to find something that accurately takes that into account.
Oh, yeah, so there's been 2 points on complexity. Yes, nursing teams have a complexity tool. I was speaking to a dietitian in London yesterday, and she developed a complexity tool for dietetics, which looks great. It's then how do we apply that to your caseload? So of your 100 patients, how many meet complexity A, how many meet B, etc. In the D2A work we've done, we've tried to discuss it like an average. So we said on an average basis across this pathway, this one patient might take me 4 hours, 3 patients might take me an hour, another one might take me half an hour. Where do we feel as a group of clinicians who are experts in the area, where would they place that as an average? So that's 2 ways we've looked at approaching that. I won't say one's better than the other. We're going to try them both out and see how it goes.
I just want to say we're very keen on PDSA, and I know, there's something about actually doing that a little bit to start with, and then
and they're doing measure your outcomes. Was it okay or not with that team? So, and then actually no, that didn't work. So it's going to be that sort of cycle. Okay. I'm not going to have a magic bullet for you all. I'm sorry to say that. There you go. It's done. But hopefully getting people engaged with this sort of work and getting people's evidence collated together will give us a greater body of evidence to move forward.
Okay, thank you. Thanks very much.
Thanks, Rob. Have we got any other questions from anybody? Or comments? Deanne, I think you might be about to type. No?
I was going to type it actually, but I can say it. I just think because there's lots of different teams and services who've sort of done lots of thinking around caseload weighting and complexity and acuity, but I don't think what we've always been great at doing is actually putting them out there and sharing them, because there's lots of services across the whole of the country who are absolutely grappling with the workforce, the safe staffing issues, concerns that we've got. So I think the future collaboration workspace will be really good. I think we've got to get better at sharing actually, and having the confidence. I think there is something around AHP culture that we want things to be absolutely perfect, and we're a bit nervous about somebody saying, oh, because we're good at critiquing as well. But I think we've just got to say, look, this isn't the perfect tool. This is what we're using. You know, please use it, adapt it. And I think we've got to do that more. So I was really pleased to hear about the future collaborations space. But we need to also get better as a network of AHPs at sharing confidently and not holding stuff back. Yeah,
so if there's anything to go on that page, obviously that'd be great to put stuff on there. Absolutely agree with you that things won't be perfect. You know, if we get to a conclusion with this D2A work, I'll be sharing a tool that's far from perfect, but I'll be able to say this is a methodology we followed and we're trying it out a bit more. AHP Pro, the same thing. We've looked at it, and then East and North Arts are going to try it out and see if that works for them. It's not going to be perfect, but I think you're right. People want to share the finished article, but actually, in reality, that might take a bit of time getting there, and it might take a few of us being brave enough to share the imperfect. To be, you know, people will praise us a bit, I'm sure, but also might say, oh, that could have been a bit better. Well, that's great. Let's make it a bit better then. Yeah, absolutely. So Catherine's got a hand there.
I was just going to say that the other thing that we need to perfect is actually writing it down, because a lot of us have kind of learnt bits off people over the years and then tweaked them. But actually, we never ever write it down. It's kind of one of those things that if you're lucky, gets passed on and adapted. But yeah, we're not good at that, are we?
I'm not either, Catherine, and I'm rubbish at sharing stuff. So I need to get that's, you know, that could be my aim with these bits of work.
I'm quite happy to share stuff. I'm quite happy to sit alongside somebody and share my knowledge and learn off other people. But it's just the writing down. It's that time to do that, isn't it?
Yeah, absolutely. Debbie?
Hi, I just wanted to pick your brains about, because I come from the community stroke and neurology team. So obviously we've got stroke and neuro patients together in one service, which is not that common from what I understand nationally. Usually they're quite separate from each other. But I just wondered if you knew of any teams that we could touch base with that have done any kind of demand and capacity work or job, the modelling and things like that, so that we could share what we'd done with them as a comparison to see if they've got any good ideas that we could take on board.
Yes, there's a few organisations try to model through where they've got that's part of the complex issue for AHPs is we manage lots of different pathways. So your stroke stuff you might model and your neurologist might model differently. So I can't think of a trust that specifically raised a stroke neuro example, but there is it was in North Tees actually, just near where I'm physically based. And they were trying to look at a team that covered a number of different areas and how they would model that. So I need to touch base with them again, but if you by all means get in touch, Debbie, and we can even just have a look at it together, and I could see if there's any learning from elsewhere. Because I think that's a key point. Is you'll have to model the pathways 1, 2, 3, 4, 5, and your capacity is still only one thing. And like the D2A example, D2A is one part, but they also do 2-hour emergency response. They also do some additional generic community rehab work from referrals from other sources. So we're going to have to do the D2A pathway bit, but then they'll also have to model all the other parts for their entire team. So by all means, get in touch. I'm happy to discuss that further. And if you've got some things to share, we could maybe collate that and do that as well.
Thank you. Thanks.
I think that's right, Rob, because I think you've got to start somewhere with the basics, haven't you? And then you work it up, because obviously with every condition or with any pathway, you've then got, early intervention pathways, longer term rehab pathways, long term management pathways. You've just got so many pathways within a pathway that then links in with another pathway. And I think for us, because we think quite wide, I think we probably get a bit too big and a bit too wide, whereas I think you've just got to start somewhere, give it a go, and then kind of like move on and evolve it. But I think it is the key thing. I think, Deanna, you're absolutely right, is how do we share this up and across and wider so we can all learn across organisations. And I think that's the bit that I think is definitely required. So have we got any other questions before I pass you on? Oh no, Emma, yeah.
Oh, sorry, it just
we've got 4 minutes.
There may be a couple of rolled eyes at this, but there's Life QI. I mean, that would be a good opportunity to be able to share if we actually wrote it down and started to put it in sort of a structure.
I think there's forums, isn't there? We can share things in, and that's another good example, Emma, of a forum we can use certainly. I think we'll all collectively take away. Let's share stuff a bit better. And yeah, next AHP's Day we'll have thousands of examples we'll be sharing.
Absolutely. Any other questions or comments from anybody?
Sorry, can I just make one last one, Debbie? Just, I think it is really important as AHPs that we do get this right for a number of different reasons. And I think my experience of the role that I've been in for the last year and a half, nursing and the medics, they have really quite significant reports at trust board level on safer staffing. They're reporting them monthly. They're going to the quality assurance. They're very, I mean, and I know it's a very different context, and it is harder in nursing for community safe staffing reports as well. And it's something sort of I've been working on to get actually AHPs even described in our board reports. It's narrative based at the moment, but at least we're actually getting some description into our board reports now. But having something that is more refined and that can demonstrate actually what we mean by productivity, but also safe caseload, and then be able to triangulate across to quality data, it is really important. And I do think it's quite an urgent issue given the workforce challenge and the context we've got. So it's not a question, it's just my reflections really.
And you're absolutely right. It's a quality board point that the AHP staffing should be discussed at board level. So organisations need to be considering that, even if it is more of a narrative at present, whilst we build the data behind it. Yeah, very, very, very good observation.
Yeah, lovely. Thank you. And I think Catherine and Emma and Katie have put a few things in the chat just about how we can take the next step, certainly within LPT, within our organisation, but obviously. And that's a good start. It's a great start. And then obviously thinking wider across the LLR system, I think, is going to be key as well. So, but thank you, everybody, for that. That's great. So we'll now pass on to Amanda Mobley. So Amanda is manages the neuropsychology services within LPT, within mental health services. She's not an AHP, but I thought it was really good to have Amanda here from I don't know whether you kind of don't clash yourself as AHPs, but I thought it was really good to have Amanda here just to kind of give some examples of the work that she's done historically and from her perspective. So I'll pass you over to Amanda. Thanks, Amanda.
Thanks, Debbie. Psychology is always such a grey area, isn't it, in terms of AHPs? I feel so affiliated with AHPs, but often psychology is seen as something separate. So thank you for including me today. It's really nice to be able to come and talk. And thank you so much, Rob, for that. Was a really interesting presentation. I've taken loads of notes that I'm going to go away and loads of things to kind of look up at. I'm just, I suppose, going to talk about from a practical point of view what my experiences have been about job planning and some of the practical challenges of doing job planning, both for individuals and for teams. So it's coming at it from a slightly different perspective. So yeah, if we can go on to the next slide, please, Lucy. Okay, so Rob spoke a bit about this in terms of looking at what's clinical work and what's supporting professional activity. And one of the things that I suppose I've found the most challenging and is the most important bit, I suppose, in getting right when you're thinking about a job plan, thinking about what capacity you have within the services, what counts as clinical work. And this is in practice really quite challenging to define and can be quite difficult to break down the particular categories, particularly when you're looking across professions, because different professions might have different ways of categorizing something as clinical. So some places where I've worked, clinical work is only when you're sat in front of a patient. That's the only time that's counted as clinical. The direct clinical contact is only that in that time. But what we come up with a lot in psychology is particularly that indirect working. So what happens when you're talking to a staff member or working with a staff team to support them with someone who has issues with complex, challenging behaviour issues, for example. How is that classed as clinical work, or is that classed as a supporting professional activity? And how does that get recorded? I think that's something Rob mentioned as well. How does that get recorded on the electronic note-keeping system? What about the informal conversations that you have with colleagues about a client, which is clinical because you're having a conversation about a patient? You're trying to work out how to work together with someone or trying to think through something. But again, what is that classed as clinical and non-clinical in practice? Things like MDT meetings. Typically are classed as kind of non-clinical, but actually you're talking through patient care. You're talking about actually what support that patient might be getting, what input that individual is receiving from a team, and you are talking about a specific individual. You're not talking about general clinical care. You're talking about a specific individual. And within our psychology professional guidelines, we also have the role of supervision is also really key in terms of what's being provided clinically. So our professional guidelines suggest that, for example, trainees, where we're clinically responsible for their work, that counts as our clinical time. Our supervision that we're offering trainees counts as clinical time. Because we are professionally responsible for the work of that individual. So any supervision we provide is counted as clinical time within our role. So I think it's really important to define what you're, and in some ways it doesn't matter how you define it, but it's really important to get that definition first before you start thinking about making that job plan. Because actually, if you're trying to work out what your capacity is and you're only including direct patient time, you're going to have to look at a slightly different job plan than if your capacity includes direct patient time, report writing, filling in referral forms, scoring up assessments, MDT meetings. Your clinical time is going to look really different. And so it's really important to, before you get that job plan worked up, sit down and work out what are you defining as clinical? How are you defining that as something that you're thinking of as clinical work and something that you're thinking of as a supporting professional activity? And each service and each profession may have a different way of doing that. And that's okay. It's just about getting that established to start with, so that you're all starting from a clear expectation around what is going to be that clinical, non-clinical split. And so I suppose that's the bit where I've always found is the clearest place to start, because it's so grey. So trying to get that clarified is the first port of call. So we can go on to the next slide, please. So then I've gone through a bit about the practical stuff, and I'm sure this is stuff that everyone has been doing, but I suppose I wanted to highlight a couple of parts of this that are have been quite interesting as I've been working through. So to start with, obviously you're looking at working hours and breaks, and that is sometimes easier said than done, because actually a lot of people are working part-time or working extended hours. So they might be working 30 hours, but they're doing 8 till 6, 4 days a week, rather than 9 till 5, 5 days a week. Or there might be people who are working different hours on different days because they have different commitments at home and they're trying to balance those things. So sometimes people might be doing a short day one day, a long day another day. And actually trying to establish that to start with can be quite difficult, especially if people have multiple roles. So even just starting at that point, being really clear about what the expectation is, what working hours people are going to be doing, and whether people are going to be working flexibly. Very often there is some flexibility needed within some of our roles, and people sometimes do need to step outside of that. So really looking at that as kind of the first port of call, and then working out that clinical, non-clinical split based on the definition that you're using within your team, within your service. And then I've tended to start by looking at what has to be covered. So I have often looked at this by looking at a team to start with. So what things have to be covered by the team, and then how can that be spread evenly across a team, so that you're not finding one person is taking the bulk of a particular type of work. Looking at actually what the team external commitments are, the things that we don't have any control over, but need to be covered by the team, by the service. So particular meeting, a regional meeting, an external trust meeting, things that can't be moved, they're not flexible at all. And then thinking about I try and look at it on a sessional basis rather than look at it on a specific hour by hour basis, although I have done that with some people, just because it can be harder to chop and change back between if you're doing kind of a service development role to then start thinking about your clinical role. So try and keep it on a sessional basis, I've found is makes it the job plan easier to manage. So try and keep all the clinical work together in a particular session, try and keep the service development work or supervision all together where it's possible to, and try and set the expectation for that session as well. So some job plans that I've seen have been like, this is a clinical session, but actually it's really helpful to set the expectation of what is involved in that clinical session. So firstly, what the content of that session is going to be. Is that clinical session going to be direct patient contact? Is that clinical session going to be a consultation time? Is that clinical session going to be offering supervision to trainees? Is that clinical session going to be doing group work? So being quite clear about what the expectation of that clinical session is, and if it is a clinical session where that person's going to see patients, how many patients are you looking at seeing? So you're not just saying that's a clinical session, you know, that's the time available. You're saying, well, that's probably going to be 2 home visits, or that's going to be 3 people on a telephone follow-up. And you might want to specify whether you're looking at new assessments, whether you're looking at follow-ups, and kind of go down into the detail of it, depending on kind of how able and flexible the service needs to be as well. And then I've put in there a marker because I think it's really important to be realistic about how long tasks take. There's kind of the theory about how long things take, and I know I've been a victim of doing this a lot, saying that will take me 10 minutes, that's fine. In practice, it does not take me 10 minutes. In practice, it'll take me an hour. And actually, when I've only given myself 10 minutes or said, well, that task will only take me half an hour on my job plan, what happens is I get into a situation where my job plan isn't working for me because I have loads of work spilling out into other areas and not contained, because I'm not being realistic about how long it takes me to do that piece of work. So some of the things I've done is almost like tracked my time. So when I've been writing a report, I'll time how long it takes me to write that report and see how long that takes and go, well, that took an hour, that took 2 hours. I need to know that. And rather than try and be unrealistic, be like, no, that's how long that takes me. I need to make sure I've factored that time into my job plan. So that's just a marker, just to say something from my own bitter experience of writing job plans and then them not quite translating into what I wanted. I've also found it's helpful to try and keep session related admin close to the session. So if your session is an hour, I've then tried to go, well, I'll try and do my notes afterwards. So if you're looking at kind of an outpatient service, obviously inpatient service is slightly different, but if in an outpatient service, I try to kind of keep those things close together, or community service, because otherwise it's hard to, if you bulk it together, sort of say clinical time, admin time, it can be difficult to remember all of the content of the clinical work, and it can feel hard to feel that can get contained. The other thing I would also say is colour code job plans if you can. I'm a big fan of, I'm sure I'm preaching to the converted, I'm a big fan of colour coding things, and being having something really visual for people when they're doing their job plan, so they can really see that. And also be mindful of things like rotating job plans, particularly for part-time staff. I've found that a rotating job plan where you might have like week A, this is what week A looks like, and week B, this is what week B looks like, are really helpful when you've got people who are only in 1 or 2 days a week, and they need to have that option of doing various things, but they can't practically fit that all into a day or 2 days a week. I've been on a 4-week rotating job plan before, and it does give some more flexibility to be able to look at your clinical capacity in a different way. So it doesn't necessarily have to be 60% of that week. It might be 60% of your time over the course of a month, so you can look at your clinical capacity in a different way as well. It doesn't just have to be weekly, is the other thing I just mentioned. So we can go on to the next one, please. So this is just an example. This is a very sort of loose example, but I suppose this is I've got at the bottom where it's defined what clinical work, what the clinical expectation is going to be. I've included MDT meetings in here as clinical work because that is clinical discussion, and the expectation of an MDT meeting might be to feed in to the clinical discussion, even for patients you're not directly involved in. So I've included that as clinical work. And then you can see that I've broken it down into what the clinical sessions involve. So there's on the Monday, you've got the clinical session where you've got 2 patients 2 home visits. They're likely to be new patients. On the Tuesday, you've got clinical 3 patients online or on the phone, also including report writing, group work. And what I've also tried to demonstrate with this is the need to try and balance things across the week as well. So the need to probably not sort of front load kind of all clinical sessions into one slot. You might want to spread that out over the course of the week so that there's some maybe flexibility within that day if something comes up. Particularly, we know from clinical work, things do come up. And, you know, things do need to be acted on straight away. It gives a little bit more flexibility if something needs to be responded to. So I sort of try and get a bit of a balance, as I'm sure other people do as well, for when we're doing job plans with people, so that each day there's that scope for flexibility. So if we can go on to the next one. Okay, so the things I found really helpful about job planning are it does set a really clear expectation of what the person is expecting for their week and what others are expecting of them. So we can be really clear. We know how many people are going to be seen within that service. It really helps when you're looking at where there are more people coming into a service than could be seen. It helps to go back to commissioners, it helps to go back to service managers and say, look, this is how many people can be seen in a week. This is what the expectation is that we have of our staff member. And so this is when we're looking at more referrals than that, we're not going to be able to meet that expectation. So it is a really helpful conversation to start that initial dialogue when you're talking about the need for extra resources as well, because you're saying, you know, this is what our capacity is, not just in hours, but in someone's actual week. We can't, you know, this is how much flexibility we have. And I've also found it really helpful when people are remote working, because it gives a really clear idea of where people are and what they're doing when you're not physically on site with people and you're not expecting someone to come back into the office. You're not necessarily going to see them. You have a sense of how someone's day is likely to be going. You know, if they need to be, you know, if they're seeing new patients, they're likely to maybe need some additional time because it can be a bit more unpredictable. So you can kind of make sure that you're supporting staff as well throughout the week when they need to be supported, when people are working remotely. And I found that really helpful just to get a sense of where people are in the week, especially because in our service in neuropsychology, we have lots of people working part-time across multiple services, you know, different services on different days. So trying to have a sense of where people are really helps from my point of view, that I can keep a track of that. And I think people can find it really I know I find my job plan quite containing when it's working, and when I'm kind of sticking to it, I know what to expect from that day, and I know kind of where if I can't do that bit of work straight away, I know when I can do it, so I know when I can fit it in. And so I find it really helps contain that anxiety of like a million emails coming in and me going, when am I going to do all this? And I'd be like, no, it's fine, I've got time penciled in on Thursday, I know I can pick that up then. So I find that can be really helpful and help that forward planning for the week, so I know where I'm going to do that work. So if someone's, can you review this document for me? Can you write a bit of for this thing? I can say, yeah, I can hopefully pick that up on this day if nothing else comes up. And it also ensures everyone has protected time to do the things that really motivate them about their role as well. So that might be the clinical work, that might be service development, that might be group work, that might be supervision. And it just really make sure that everyone has within their week something that really helps keep them engaged in the work, something that really helps keep them motivated and keeps them coming into work, because sometimes when work's busy and stressful, it can be really hard to keep that motivation up. So having a job plan where you have protected time, and you know that that's respected by your colleagues, you know that's respected by your manager, you know that's been signed off, to have that protective time for research or that protected time for something else, is something that I think is really essential to, especially at the moment when everyone's under such increasing pressure. So next slide. So the challenges, maybe I should have done challenges and then benefits to finish on more of a positive note, but I just wanted to raise some of the challenges that have come up as well. I don't have answers to this, but I would be really interested to hear other people's experiences. So I find it really challenging thinking about job plans when people are working extended hours or part-time hours or variable hours. Some of that is because the day feels really full. So if someone's working a 30-hour week, but over a 37.5-hour week, but over 4 days, the day can look really full. So when I'm looking at it externally, I go, oh, that feels like a really heavy clinical day. But actually, if that was spread out over 5 days, that would look really different. So sometimes it's having that conversation about whether that feels okay, but ensuring you're still getting the same clinical capacity, and ensuring that people understand that if they're doing extended hours, their days might feel really intense because they are compressing a full working week into into less time. So it's just being aware of that, I suppose. And part-time hours I found particularly difficult from my own perspective, because external commitments often don't fit within part-time hours. And it's really hard to be flexible when you've only got, say, so I work 5 sessions a week. When you've only got 5 sessions a week, it's actually really hard to be flexible if something comes up on a day where it's not a day I normally work, or it's not a day that is it's normally a day, it's a clinical day, but actually that's something that needs to be picked up. So I suppose it's just about the challenges of managing that, and I don't have any easy answers to that. That's the main challenge to my own job plan when I'm trying to do my job plan, is trying to meet the needs of what the services want, what external things are coming in, and meet my job plan. So getting that balance between keeping the boundary of my job plan and also being able to be flexible and support colleagues and do the work that I want to do in the way I want to do it. And that can be especially challenging. So my working days are Monday, Tuesday, Thursday. Mondays is invariably a bank holiday, which has a significant knock-on impact on my job plan. So I have to be really mindful about that my job plan incorporates a Monday. And if that's a bank holiday, how am I going to adapt my job plan to make that work? So I would suggest really regular reviews of job plans. I know it says at least annually, but in my experience, I found you need to review it more regularly than that, because they slip really quickly, and it can be really hard to keep that job plan focused. And I would also suggest working with personal strengths as well. So everyone's job plan is going to look different. So I know that in the morning, I'm not necessarily very good at coming in and being really chatty. I need a bit of time to kind of build up in the morning. So I'm not very good at booking meetings first thing in the morning. My brain takes a bit of time to get going. I'm better at reviewing information, writing reports in the morning, and that's when I feel like that work is better suited for me. Other people would be completely different and would want to come in and be like, right, I want that burst of energy in the morning where I can be really sort of have lots of clinical contact and be really productive. And then I'm going to do my reports later on in the day when that energy is kind of less, and I want more focused time. So I think it's about working with people at an individual level as well to look at personal strengths and kind of what's going on. And that is an interesting challenge as well, just going back to the compressed hours element as well. Of managing compressed hours is that often you're looking at when patients want to be seen as well. Some patients don't want to be seen at 8 in the morning or 6 at night. So there's an element of thinking about when patients want that clinical contact as well. So you might say we have clinical capacity, but actually if that's not being picked up because that's not a session that's desirable, and in my experience most people don't choose a session at 8 in the morning, that might just be psychologists. Maybe they just don't want to see psychologists at 8 in the morning, which I think is probably fair enough. I'm not sure I would either. So I think it's kind of just being mindful of that when you're thinking through that job plan. There's also a real challenge about things you need to respond to quickly. So thinking about the role of having a flexible slot, or if you have managerial responsibility, kind of do you have a part of the session each day where you can respond to things like sickness absences or the COVID regulations and things like that. Again, trying to kind of make sure that there is that flexibility to do things that come up that need to be dealt with that day, that needs a 24-hour response or needs a 72-hour response. It's kind of having that flexibility. So thinking about how you factor that in. I don't, again, have any easy answers to that, but I would be really interested to hear what other people do to try and factor that in. There might be some lessons I can take from that. And the other thing that I have found is that responding to emails. So I found in practice, the responding to emails is something that I very rarely put in my job plan, but actually takes a big chunk of my time. So if it takes 5 minutes to respond to an email, which if you're trying to make a time to meet with somebody, you've got to go back to your diary, you've got to see where your slots are. It could easily take 5 minutes to respond to an email. If that email has got some more complex information in, you need to respond to people, and that takes 1, then you can answer 12 emails an hour. I don't know about anyone else, but I get like hundreds of emails a day. So actually, it's factoring things like that into your job plan as well that are very rarely sort of seen as a sort of tangible thing, because they're not they might be clinical or they might be non-clinical. They're kind of not one thing or another, so they tend to not be looked at. But again, I'd be interested to see how other people have management systems for their emails and how they factor that into their job plans, because that's something I've found in practice is a real challenge. So that's the end of kind of what I wanted to say. I would be really interested in anyone's thoughts or any questions anyone might have.
Thank you, Amanda. I was just about to put in the chat, I've got 1 minute to go. So that's great. Thank you for I think it's really good to hear about your individual experience and your practical examples. And also interesting to hear about it. I think as you touched on well-being as well, so I'm really keen on that as well, like how it impacts on well-being. So, but over to anybody else for comments or questions. Thank you. Debbie?
I really liked what you were saying about personal strengths, Amanda, like working towards people's personal strengths. And I think it's something that we don't often think about in relation to sort of non-patient facing things, like you were saying about I think we'd think about it for our patients, but I don't think we probably necessarily I certainly don't think about it for myself. And you've made me think about what time of day is better for me to do certain things. And I think that's the good thing about the job plan, isn't it? Is that you can, although you can have a generic job plan, you can personalise it towards people's strengths and needs. So yeah, that certainly gave me something to think about for me anyway.
It's certainly something I've thought about. I suppose that I put it in also because I've been thinking about it a lot lately. I tend to put report writing at the end of the day, but at the end of the day, I'm often really tired and I'm not good in front of a screen because I get really drained. And so I've just moved around my job plan to be like, no, I'm going to do reports in the morning. I'm going to sit down, and actually that's when I'm better working in front of a screen and typing. And then at the end of the day, I'm better doing something which involves me being maybe a bit more active and a bit more sort of engaged at a sort of social level as well. So I think it's something I think is quite important to try and get that individual approach as well to a job plan. Yeah.
Lovely, absolutely. And I think Jan just put something in the chat about heads, hearts and hands approach to finding strengths and interest, and it's a good approach. And I think it is absolutely that balance, isn't it, between we've got to think of it from an individualised personal point of view, but we've also got a job to do and we've got a capacity and demand to do, and we've got, so it's a real balance, isn't it? For me, it's a real balance between managing the staff well-being along with getting our capacity and our demand where it needs to be able to respond to the wider workforce, wider system pressures. It's a real challenge, but I think it's something that kind of we can do as AHPs, isn't it? So if there's no more questions, I'm just going to pass on to the final presentation. But if there's anything,
sorry, Debbie.
Yeah. Oh, sorry, I can't see. Sorry. Oh, sorry, Julia.
That's all right. That's okay. So Amanda's actually my manager and supervisor. Well, she's my supervisor and has done my job plan with me. So I was just thinking about what you were saying about reviewing it regularly. And I think that's probably one of the key aspects to this. And I think we often give a huge amount of effort and thought to the setting up of the job plan and everything. But actually, as you said, it so quickly can slide, can't it, if you don't keep on top of it. And obviously you bring it up with me regularly in supervision to come back to the job plan. And I think that's something that we probably need to think about in our services, is how we actually monitor that and make sure that the job plans are working and how we empower our staff to be able to say, actually, I'm struggling with this, because some people will find it more natural than others. Some people will really like that structure, thinking about the kind of individual strengths that people have. Some people will like to have, on a Monday afternoon I do this, on a Thursday I do that. Other people will naturally work more flexibly and will try to sort of be more responsive and balance things across the week and the month. So I think it's I don't know, I haven't got any answers, but I just think that's something that stood out to me, really, from my own personal experience of doing job planning with you.
Yeah, and I think definitely that reviewing process is something I've found as well. I spend loads of time doing these job plans for myself and kind of working it through. But actually, I think that review process is really important, because it is things change, services change, demands change, things outside of work change, which mean that the job plan needs to change in order to make sure that that clinical capacity is protected, and making sure that we can still do the job that we're there to do. I think having that regular review does enable that. It does enable that opportunity to really make sure that we are offering what we want to be offering. We're getting the outcomes, the clinical outcomes that we want to be getting as well.
Thank you. I think Catherine summed it up. It's a lovely big jigsaw puzzle. Absolutely is, Catherine.
It is, absolutely.
Fantastic. Yeah, lovely. Okay, so if we move on to the KINS leads, who are doing a presentation around AHP job planning and kind of the work that we've done to date within our service. So another practical kind of example. And I'll pass you over. I'm not sure who's starting, but I'll pass you over to Katie, Debs and Ruth. Thank you.
Hi. So we've just pulled together some information for you on what we as a team have done historically with job planning, and where we're at now and where we're planning to go in the very near future. So if you could just pop the next slide, Lucy. So within KINS, and certainly prior to KINS service development and becoming an actual service, we looked historically at job planning, which was mainly done in community therapy teams, and we did this work as well as early KINS work as well, on sort of pre the national guidance that Rob was talking about on job planning. So we'd already started to think about all these kinds of issues relating to staff and how we manage our demands on our time, both clinically and non-clinically. So within the early work within community therapy, we entitled it Fair Days Work. I'm not sure if everybody within the trust has heard that term being mentioned, but we entitled it Fair Days Work, and we took certain elements of that and brought it into the KINS team to look at our capacity and demand with KINS. And we did make some assumptions as part of this work. It was mainly based on us focusing on what patients' complexities were within KINS and the banding and professions of each member of staff. But we did miss some out of the sort of the non-patient facing elements within our assumptions. So we missed some of those out. So I think really we need to take those into account when we're moving forward. We were just ready to share our Fair Days work, if we're using that term, with our staff just prior to COVID. And then obviously COVID happened and that work was put on hold, and obviously services were turned upside down and around to meet patient demands at that time. So we would like to, we're now continuing with this work, and really now we want to recognise staff's additional non-patient facing demands on their time. So we think that this is really important that we do recognise this, because it's an important part of our quality of service and our service development, as well as staff's professional development, and as we've mentioned before and in the other presentations, their job satisfaction as well. It's important to recognise all of those other demands that pull on our time, not just the clinical face-to-face. So we want to work with our team and individuals within our team to develop a generic job plan with a view to then further personalising it with individual members of staff, because we recognise that everybody will have different demands on their times. We've done a lot of work around roles and responsibilities, particularly within the leadership team, to look at what expectations we have at a leadership level, and we will cascade that down to other bandings and professions within our team as well. We want to reflect and value those additional roles and responsibilities, like I've said, because they are very important. I think within KINS we do see people as leaders on various different projects. We try to incorporate everybody's input into things for service development. So we are all leaders in some shape or form. And obviously we want to further support CPD, clinical audit participation and research activities, or any other activities that might enhance individuals' professional development, as well as our service development as well. So this is why we're now re-looking at this work and changing it slightly in our approach. So I'm going to pass you on to Ruth now, who's going to go through our provisional sort of thoughts on direct clinical care and supported clinical care as well.
Thanks, Deb. So yes, this was our attempt to do what Rob was talking about in terms of working out what's direct clinical care and then what isn't, what falls into the other category. So as Amanda said, it's really important to get this right, or at least to be clear within our service what we're putting into each section. So the first slide here is what we felt, which I think is slightly different to what Amanda said, what we feel is direct clinical care. So you can see there on the slide that obviously it's all of the face-to-face or the direct contact with the patients, whether it's in person or virtual. Then we also felt the documentation of those sessions, any clinical telephone calls, referral forms or signposting, ordering of equipment, the travel we've included in that, that's all part of that direct clinical care. And lastly, our 6-month post-stroke reviews that we've just included for clarity, because within our service, that's a kind of a separate sub-service that's different to our usual direct clinical work. So that's what we feel is the direct clinical care. So next slide now, Lucy. Thank you. So this is our list of the supporting professional activities. So you can see here that we've included your supervision, and that's what you receive and what you give, and including peer supervision. We included the MDT type meetings, VARM or safeguarding, those kinds of meetings. We included that in supporting professional activities, but can clearly see why you might put that in the direct clinical as well. So then all the service development, recruitment, all those kind of extra roles that people will have. Communications, of course, including the never-ending stream of emails that we all have to do. Team meetings, we have something that we call allocation meetings as well. PDRs, not as frequent as supervision, but we still need time to incorporate those and prepare. Then other operational day-to-day duties, clinical triage of our referrals coming in, and finally students and all that is involved with looking after our future professionals. So they were our 2 lists. Over to Katie, I think now, if you are happy to move on to the next slide, Lucy.
Thanks, Ruth. So just obviously Deb's has kind of spoken about why we're doing this work within KINS, and Ruth's kind of spoken about some of the first steps we've made. And so the next steps, of which there are many. There's 4 on this slide, but there are many to come, and many probably that we're not even aware of yet, and lots that we've learnt about today. But to make a start, we've actually planned a whole team away day in a couple of weeks' time, so we can explore with the whole team the split between direct clinical care and supporting professional activities, and that will be the first step on our ladder as a whole service towards job planning. And obviously we'll be moving more from there, I guess, to kind of look at what times we allocate to face-to-face visits, whether that's virtual or a follow-up or a new assessment, and obviously kind of going along that line to really develop and completely understand what our true capacity is as a service. So that's kind of one line of work we'll be looking at. And obviously, like Deb said, what we want to move towards is producing generic job descriptions, we feel at first, kind of per band and per profession, but then definitely working with individuals to kind of change those templates, I suppose, if you like, and personalising them for each individual, so that we can really value and appreciate all of those additional roles and responsibilities that everybody within the service takes on, and they can kind of obviously all be accounted for. And we also, exactly like Amanda says, we really want this document to be a working document. We don't want this to be something we do and we pop on a shelf and we maybe look at it once a year if we're lucky. We really want this to be a real, true working document within our service, to reflect the dynamic demands on kind of our patient demands, but obviously those changing our non-patient demands, all of those changing demands on our time for trust-wide work or kind of and any other kind of initiatives that come along the way. And we'll work with our team. I think, like everyone said today, we don't have the answers as to how we keep this a dynamic document or kind of a prescription as to how often we have to review that. But this is something we really want to work with as a team and with individuals within our team as to how do we keep this a working document for them and what will be meaningful for them, because I'm sure that will be different for everybody within the service. But that's definitely within our vision to kind of keep this alive and keep moving forward and keep learning about it. So there are next steps, and a bit like I said earlier, along with everything we've heard today, we now need to add onto this list of what our next steps are, and I think they are our baby steps into a very big mountain that we have to climb. But I know we'll get there all together, and obviously sharing our ideas like we have done today. So that's just I guess a little update from KINS as to kind of what we've started and where we're up to. I don't know if anybody has got any questions following that quick tour of where we're up to at the moment.
Thank you. Fantastic. Obviously, I'm very aware of what's going on in KINS, and I think it's really good to share what's happening. I think this is coming at a pertinent time for our team as well. So, and obviously, it comes in with being able to manage our staff wellbeing, our staff productivity, as well as obviously for us our big waiting times that we obviously need to kind of address. So it's a real balance between the three, like we talked about earlier. But I think Deanne, I think you've got a question.
Yeah, it was again, I'm just sort of thinking about some of the job planning work we've done or I've been involved in before in other services, and how it's obviously sometimes what the outcome of that job planning work is, you realise actually the demand significantly outstrips the capacity to deliver the service. But what the job planning and productivity work does, it gives you a platform and a means for that discussion to be able to then have those conversations, which will now be part of our wider integrated care service. Previously would have been our CCG's commissioners, usually our CCG commissioners, there may be other commissioners as well. But without that clarity on your job planning and the demand and capacity, it's difficult to have those conversations really openly and frankly. And we have been able to do that in some services, to be able to take the data back and say, look, everyone has a clear job plan. this is what we're working to. It's reflecting the national context, and this is the difference. So, and then some difficult decisions sometimes have to be made, which either involve further investment or there has to be a change in that service delivery. But I do know from lots of the conversations we've had and I've had with our commissioning colleagues before that without that data and that robust information to take into those conversations, it makes it very difficult, and they will just ask for it, basically. So it is I think you've described it really clearly, Debbie, in saying actually it's really imperative that services do this piece of work and that people have job plans and we work on the demand capacity, even if it isn't the perfect answer. Otherwise those conversations can't happen.
Absolutely agree, Deanne. Absolutely. And I think we've done this historically, but we've done it probably a bit of a side. So we think we're clear about what our capacity and demand is, but now what we're doing is we're just making sure we've got it right with our team. And this is why we're doing this big piece of work with our service. And I think the other thing is to learn. I think, Katie, you've recently spoke to CAMS, haven't you? Because CAMS have done quite a lot of work within LPT. And I think, and there's a lead within CAMS. So I think it's about learning from each other as well across organisations. I think that's the other thing as well. Let's not reinvent the wheel here. Let's kind of learn about what's gone on before. Working with your business teams is also the really key thing. So our business team have been fantastic, and we've actually got a really good job planning workflows tool that we use. That I think, Rob, when you talked earlier about the national one, that was I can't remember what you called it, but we've got a workforce tool that the business team set up, which I think actually probably started and originated in CAMS, and that's really good. You need something like that. But I think what we shouldn't be doing is reinventing wheels. We should be sharing that work. So I think when we get to the point, certainly in our service where we're at, I think the next step will be, right, let's share, let's shout, let's kind of share, let's kind of let other people learn from it. So I think it is very, very key for us to do that. So any I'm just looking if there's anything else in the chat. Is there anybody else who's got anything else they'd like to say or comment on?
I just think, Debbie, for me, I always have to remind myself during this process, some of the stuff we've done at KINS before, we've kind of had to do at pace because of the demands on the service, and obviously things, do need to happen quite quickly, and kind of that data needs to be found quite quickly. And now we're at a place which will be brilliant to move forward and work with the service, but actually I have to keep reminding myself that these things take time, and actually we've got to do it, and we've got to do it right, and it will take us a long time to get it right, and we're on a journey all together as a service to get it right, and everyone else may well be fine with that. When my brain races ahead, I just have to keep reining myself in to know that actually this is getting it right in the long term. It's not a quick fix, is it, to kind of get the data that we need quickly, and that it will take time, and time, unfortunately, is something we don't have a lot of, isn't it? But giving ourselves that space to achieve that, I suppose.
Absolutely.
I think it's knowing that it's not going to be right first time as well. If you go right back to Rob's presentation, I think that's been a big theme throughout, that actually it's a work in progress, and it's about what you were talking about, Emma, about PDSA cycles, where we've tried this and actually that bit works really well and that bit not so well. So how can we change that? And I think for me, the job planning, when I think of it, it helps me think about different ways of working that we might not have thought of before. It might be teams telling you, actually, we could try this, we could try that, it's about collecting ideas, isn't it? And trying different ways to see what is going to be the best way for your service, I suppose, as a starting point.
Yeah. Emma?
Just going to say, I agree wholeheartedly. I think the trepidation comes from actually selling this to the teams to make sure that they don't see it as a threat, or it's out to try and squeeze an extra pound of flesh out of people when they already feel under pressure. So I'd be interested, Debbie, perhaps we need to share some ideas about how you work with the team through it, and how you overcame some of the perhaps pushback you may have had initially, if you had any at all, and you may not have had any.
Well, we're just about to share it with our team again, So on this away day, like Katie was saying, so I'd be quite happy to chat with you after we've done that, Emma.
Yeah, that'd be good. Thanks, Debbie.
Yeah.
But I think we've got lessons to learn from history as well. So I think, and that's what we've definitely taken into consideration in terms of what we've done historically. The other thing we probably haven't touched on today, which we were hoping to get, is the IT side. You really need somebody really good with data, numbers, figures, IT within the team to be able to really model it up. Lucy is our absolute expert within KINS.
Definitely.
And I think you need a few Lucys. You need to knit a few Lucys. And I think that's the other thing. You do need some people that are really good with spreadsheets, numbers and things like that. While the business team will help, you need somebody clinically within your team as well. And that really has its advantage to help you do your modelling. Because and that is the other thing, you know, see who have you got in your team who you can spot who's really good with stuff like this. And within LPT, we were going to have Felicity. I don't know if anybody's come across Felicity Norris, who used to work in MSK physio. She's a physio by background. She now works in the IT team, and she was absolutely instrumental in MSK a good few years ago, setting up all the IT data side of things, of capacity demand modelling and job planning. And she's a really good point of contact for us as well. So she couldn't talk today, but I think let's not lose sight of that kind of side of it as well. So because that's so key for all our services. Okay, so unless there's anything else anybody's like to say, I don't know if Rob, you've got a final word you'd like to come in and just kind of say anything.
No final word. I think it's all been great to hear your little examples of how things are progressing, and I'm sure they'll continue to progress really well from the learning that you're sharing there. So thank you very much for having me. It's been a really good discussion. I hope your discussions go well for the rest of the weeks. I know these are obviously planned on a daily basis. So yeah, no, thanks again.
And thank you for your time as well, Rob. It's been really fantastic to have you with us today. And thanks to everybody else for the discussion. It's been really great and really good. And I think let's just make this part of the start of the journey, I guess. And let's not lose sight of what we're all doing and celebrate what we're doing and be brave and share what we're doing. And let's move forward and kind of show everybody else what we can do and what we can achieve as AHPs. So thank you, everybody. Thanks very much. And I'll see you all soon in the next session. Whenever that might be, I can't remember. Thanks, everybody. You take care.
Bye-bye.
Bye. Bye.
Debbie, do you want to hang on a moment?
Yeah, of course. Yeah, absolutely.